Hi, my name is Jacqueline Nguyen, and I'm part of Group 10. Our group did our Genetics and Medicine project poster on Beckwith-Wiedemann syndrome. So, what is Beckwith-Wiedemann syndrome? Beckwith-Wiedemann syndrome, also known as BWS, is a genomic imprinting growth disorder. This disorder affects chromosome 11 and the expression of IGF2 and H19 growth factors. Genomic imprinting is defined by Catchpole et al. As a mechanism by which the activity of genes may be altered epigenetically in a manner dependent on the parent origin of each of the two alleles. This disorder is heterogeneous, so different causes can affect the prevalence of this disorder. Looking at the mode of inheritance for BWS, we see that it can occur through inherited and non-inherited pathologies. Although the disorder can be inherited, it is more common in sporadic cases. Only about 15% of cases of BWS are inherited, while the rest are due to sporadic cases caused by genetic mutations or errors. These mutations and errors occur through uniparental disomy, paternally inherited duplications, maternally inherited balanced or rearrangements, or other imprinting errors that will be elaborated on later.
Beckwith-Wiedemann syndrome can be diagnosed by various methods like clinical evaluations, phenotypic presentations, and cytogenetic and molecular testing by detecting abnormalities in chromosome 11p15. The different analyses that can be performed are 11p15.5 methylation analysis, identifying the number of copies of imprinting control regions, in which there are normally two copies, and conducting CDKN1C sequencing to detect any changes in the CDKN1C gene. And with these analyses, the signs that one typically looks for are the loss of methylation on the maternal chromosome at imprinting center 2, or IC2, which is presented in about 50% of affected individuals, paternal uniparental disomy, or when both copies of a chromosome pair are from one parent, for chromosome 11p15, which is presented in about 20% of affected individuals, and a gain of methylation on the maternal center 1, seen in about 5% of affected individuals. So these signs are what you typically see as a result in cytogenetic and molecular testing for BWS.
Our gene of interest is located on chromosome 11p15.5, which is this short arm right over here. And taking a look at the bottom half of this graphic, we can see that according to Eggerman 2016, the region runs about 1 megabase in length and has two distinct imprinting control regions. These regions, as you can see here, there's one right here and another right here, are basically areas that control expressions of certain genes, depending on whether or not it is methylated. In this graphic, we can see that these little circles with sticks, as you can see right here, means that the area is methylated. So in the maternal form of the chromosome, QC and Q1 is methylated, which leads to the expression of H19 and this QC and Q1. And ultimately, this leads to limiting field growth and making sure that doesn't get out of hand. Alternatively, we can look at the paternal form of the chromosome. You can see that this same gene is not methylated, it's unmethylated, and rather the area just before the IGF2 gene is methylated. So therefore, we have expression of the IGF2, and this promotes fetal growth. So essentially, these work together to kind of counterbalance and make sure that there's an appropriate amount of fetal growth.
I'm going to be going over the mutation section. As mentioned before, BWS is caused by genetic alteration to chromosome 11, which is also known more specifically as 11p15.5. Let's get into the causes and mutation types of BWS. So I'm first going to discuss paternal uniparental disomy. In normal cases, people are supposed to have two chromosome copies. They usually inherit one chromosome copy from the mother and another chromosome copy from the father. However, some people with BWS have been found to have an issue with their chromosome inheritance. Instead of receiving a chromosome from the mother and father, they receive two active chromosomes from the father. The lack of the chromosome from the mother facilitates the prevalence of the BWS phenotype. Moving on to the genetic mutations, we are first going to examine point mutations that are linked with causing BWS. A point mutation occurs when there's a genetic addition, deletion, or alteration. When linking it to BWS, this point mutation specifically occurs in CDKN1C. The alteration of CDKN1C affects fetal growth. Another mutation that occurs are microdeletions, which occurs when a piece of the chromosome is missing. Microdeletions are typically not visible with light microscopy, and cytogenetic practices must be used to observe the deletions. These microdeletions occur in KVDMR6 or H19DMR7. The loss and alterations in KVDMR6 and H19DMR7 contribute to the lack of maternal expression. These sum up the main causes and mutations that are linked to BWS. Overall, the causes and mutations decrease the expression of the maternal gene, known as CDKN1C, and increase the expression of the paternal gene, IFG2, which promotes the BWS phenotype.
Beckwith-Wiedemann syndrome is phenotypically recognized by general overgrowth, and it is usually recognized at birth. The first sign is macrosomia at birth, which is a large birth weight and length compared to the typical gestational measurements. Other common signs are hemihyperplasia, which is an overgrowth on one side or just one part of the body, and macroglossia, which is an enlarged tongue. Hypoglycemia is also a sign, which is low blood sugar levels, and this lasts typically through the newborn stages, but it can carry into childhood and adulthood due to hyperinsulinism. Earlobe abnormalities can also be present, which includes pits or creases in the earlobe or behind the ear, and enlarged abdominal organs such as the kidney or pancreas or abdominal defects may also occur with BWS, like abdominal protrusion. And there is an increased risk for developing certain cancers during childhood, but these can be treated. And a less common sign is pink or red birthmarks on the face, but this sign can be completely normal in infants, so it doesn't necessarily indicate BWS. And this figure on the bottom shows an infant with macroglossia or an enlarged tongue from Beckwith-Wiedemann syndrome.
There is no current treatment for BWS. Therefore, the treatment of manifestations of symptoms and secondary complications are recommended. As mentioned earlier in this presentation, hypoglycemia, amemphilase, and hemihyperplasia are all common symptoms of those BWS. Medication for hypoglycemia, abdominal wall surgery for amemphilase, and surgery to decrease hemihyperplasia are all current treatments used to help ease the symptoms of those with BWS. There is no current gene therapies used to help BWS. However, researchers are looking into gene therapies such as mechanistic target of ramphasin inhibitors or glucagon-like peptide-1 receptor antagonists in their treatment in hypoglycemia. Due to the high amount of patients with BWS having issues with hypoglycemia, researchers are looking into how gene therapies for hypoglycemia can help with BWS.